Well, thank you very much, Rachel, and thank you everyone for having me here this morning. When I was initially asked to speak on this subject, I thought I would title the talk, When Can We Fix Neck Pain? And giving it some thought, I decided to expand it a little more than that. Go over, provide a general overview of the basis for neck pain. How common is it? Review the basic anatomy quickly and the underlying reasons that patients have neck pain. There are a number of clinical syndromes, so even though I've titled this, When Can We Fix Neck Pain? I'm going to elaborate on neck pain, arm pain, and something else we commonly treat, cervical myelopathy. I'll go over specific operations that we do most commonly, why we do them, how we do them, and how the patients do after those operations, and then summarize at the end. It's a pretty common problem that we deal with, clearly. Over our lifetimes, 2/3 of people will develop neck pain. At any one point in time, something like 10% of people will have neck pain. And over time, as many as 5% of the population will be significantly disabled by pain. This is for neck pain. Arm pain is somewhat less common, but still a significant issue. And the incidence for this is just under 1 in 1,000. The cost to the system, and I'll go into this on the next few slides, is substantial. In 2006, for example, where this is the most recent data I was able to put together, in the US, over 10 million patient visits, different encounters occurred because of neck pain and associated symptoms. This accounted for over 1% of all visits. And the vast majority of these patients were adults of working age, as you can see. And in terms of actual financial costs, the impact is significant because it affects the people that are major parts of productivity in society. Healthcare workers, obviously, that's relevant to us. Office workers are not spared from neck pain and arm pain. In the Netherlands, where there is somewhat more discrete data than is available in the US for this subject, over 10 years ago, the cost to the system for neck pain was almost $1 billion. A quarter of this was on direct healthcare costs, and 3/4 of this was on productivity loss. In the US, you can imagine this is an even bigger problem. The US economy is something like 20 times larger the economy of the Netherlands. And all spine conditions, for example, in the US, just over 5 years ago, cost the system almost $200 billion, and cervical spine problems were about half of this. So going over the basic anatomy that we deal with, many of you are familiar with this. We basically are dealing with the vertebrae, with the intervening discs and the spinal cord, exiting nerve roots, and the surrounding joints. That is the disc that we are operating on most frequently, and the facet joint from the back of the spine, so to speak. And these cause pain in a number of different ways. Most commonly, we're dealing with direct compression of nerves. Instability can cause compression of the nerves and pain by other mechanisms. Disc degeneration itself probably causes pain, though this is a debated subject extensively. Arthritis in the facet joints will cause pain, and then there are other less common things that we deal with as well. But even more fundamentally, the pain usually arises either because there's mechanical compression of nerve structures, or the presence of inflammatory mediators that irritate the nerves that sense pain. So going back to the imaging, we're usually trying to demonstrate that there is adequate room around the neural structures to avoid compression. So on the left-sided image, you can see there is plenty of room around the spinal cord. I put the blue lines to help visualize the extent of room around the spinal cord, and you can follow the white CSF from the base of the brain down the rest of the spinal canal. And on the right-sided image, the spinal cord is free of pressure all around. There is white CSF around it, and the foramina through which the nerves exit on both sides are wide open here. And I'll come back and forth between normal and abnormal images during the course of the talk, but this is sort of a reference baseline that we compare abnormal images with. For example, here, compared to the previous slide, you can see disc herniations at those two levels. We've lost the normal space in front of the spinal cord because there's protrusion of discs there. And on this cross section, there is the same disc herniation shown a little better here. That is the protrusion of disc material. X-rays probably are less often relied on now than was the case several decades ago because MRIs have become the gold standard. But on X-rays, we can get a lot of useful information. This X-ray shows relatively normal alignment of the spine. There's a gentle curve to the spine with the spine convex facing forwards. There are abnormal states that will demonstrate a number of things. For example, on the left side, this patient has lost her normal lordosis and is kyphotic. On the right side, there is instability. I've shown just X-rays with the patient flexing her neck here, but you can see that this vertebra doesn't quite line up with that, is translated forwards. That normal alignment is maintained down here, but is abnormal here, and instability like this will cause neck pain. Other things we'll look for on imaging, a CAT scan on the left side here, for example, shows failure of fusion to occur after an anterior discectomy and fusion. So this patient, for example, had a 2-level discectomy and fusion. The fusion is solid here. You can no longer discern where the bone graft was because it's completely incorporated into the nearby vertebrae. But here you still see remnants of the bone graft that was put in with the dark space around the bone graft representing a gap that has not filled in with new bone formation. Right side, other things we'll look for on X-rays, for example, this screw inserted into the vertebra is broken there. It's a subtle finding, but you can see this screw is different from this screw, for example. And that break in the screw, as well as the backing out of the head of that screw, are signs that fusion may not have occurred, and there is movement across the non-fused segment that is causing the hardware to loosen and ultimately break. But some of these we'll go into again in the course of the talk. Now, take into account that when we look at these abnormal findings on imaging, that most importantly with diagnosing and treating patients is the fact that abnormal findings on imaging are very common in the population. On X-ray, as you can imagine, with advancing age, abnormal findings become more and more common. By the time individuals are in their 60s, you will find abnormal X-ray findings in almost 100% of patients. MRIs, which obviously we see more frequently for degenerative disease, also show significant findings. So in adults over 40 years old, disc degeneration is present in almost half of individuals. Even if we discounted disc degeneration, significant findings like herniation are present in 5 to 10% of people. Stenosis is present in up to 20% of individuals over 40 years old. So these are important things to take into account. We for one thing, we don't treat MRIs when patients are asymptomatic. A lot of the time patients can be reassured that they do not necessarily require intervention and are not at risk with day-to-day activities. But importantly, it often gives us reason to step back and decide whether intervention is needed simply because a patient has symptoms and abnormal findings. So I'll go into specific syndromes now. Most commonly, we deal with arm pain. I'll use the terms arm pain and radiculopathy somewhat interchangeably during the talk. And I'll try to separate out to some extent arm pain from neck pain. But typically with radiculopathy, we're talking about some combination of arm pain, weakness, and numbness to varying extents. I mean, the most common patients we're dealing with have arm pain, but usually there'll be a combination of these from direct nerve compression. The most common thing we're treating is probably a disc herniation. You'll often see the acronym or abbreviation HNP, which stands for herniated nucleus pulposus. But the other common problem is spondylosis. Spondylosis is, strictly speaking, arthritis in the spine. So we don't often use the term spine arthritis, but spondylosis instead. Spondylosis will cause enlargement of joints, cause bone spurs to form. These compressed nerves. So disc herniations and spondylosis account for most of the cases of radiculopathy we see in the spine, in the cervical spine certainly. So looking at disc herniation specifically, obviously not all get treated surgically. Many respond very well to non-surgical treatment, including anti-inflammatories for medication, physical therapy. Traction doesn't have great support in the literature for it, but causes little harm to patients, and many individuals feel good with it. But with time and non-surgical treatment, almost 90% of people will get better and not require surgery. And in fact, 50% of people who have an episode of arm pain don't necessarily have a recurrence. So if they do well, there's a reasonable chance they'll not just not require surgery, but not have a recurrent episode requiring any treatment. The patients who end up needing surgery will need surgery for specific reasons. A significant neurologic deficit, weakness in particular. If you have inability to use your dominant arm, that usually will be an indication for surgery if there's weakness. Progressive symptoms over an extended period of time will usually drive surgery, but the most common thing we're operating on is usually failure to improve with non-operative care. Pain that has persisted, for example, for months is the most common reason we'll operate. So going back to this image I showed earlier, this patient has disc herniations at a couple of levels, most significantly here. If this patient has failed conservative treatment and has significant pain, say 3 months after the onset of symptoms, the most common treatment that they're offered for a disc herniation is an anterior discectomy and fusion. These have been done since the 1960s in more or less the same way. There have been refinements to technique along the way, the sort of bone grafts and fixation we use, but the operation remains fundamentally the same. These operations are done under general anesthesia with the patient supine. The incisions are usually transverse incisions across the front of the neck. Which side is used for the operation really depends more on surgeon preference than anything else. There are theoretical reasons for choosing the right side over the left side or vice versa, but truly at the end of the day, in 2013, it boils down more to surgeon preference than anything else. Besides the skin and the thin platysma muscle beneath the skin, there's very little that's actually cut. A lot of patients are horrified at the idea of an anterior neck operation, thinking of it as more invasive than anything that can be done on the spine. But in reality, there is very little that's truly cut during these operations. Most structures are just retracted one way or the other to get a direct view of the front of the spine. The disc material is removed. Various instruments are used to get all the material out of the disc space, remove any bone spurs that might be present that cause pressure on the spinal cord and nerves. And typically, this wasn't always the case, say 15, 20 years ago, but typically now a fusion is performed at the same time. One reason for performing a fusion is inserting a solid piece of bone there maintains the height of that disc space, which indirectly keeps that space through which the nerve comes out open. Patients 20 years ago did quite often reasonably well with no deliberate fusion performed, so this space was just allowed to collapse on itself. But there is a delayed incidence of iatrogenic, if you will, narrowing of that opening, and the patient developed symptoms again down the road, either from instability or excessive motion at that level, or just frank height loss and compression of the nerve root. So that's one of the reasons that fusions get performed now to try to maintain long-term results. Bone needs time to become incorporated there, so even though the operation is called a fusion, the reality is so, on the side, that's the bone graft that becomes incorporated over time with the vertebrae held in place by screws, which in reality are usually not doing anything 6-12 months later, but we don't go back to take them out once they've done their job. With a typical post-op course for these patients, this is what those of you who work on the floors see often. Most patients see an early improvement in their arm symptoms, especially if there's pain. The extent and the speed with which numbness and weakness resolve is variable. Some people notice a big change straight away, but it's not unusual that symptoms will drag out for weeks and months after that. Pain is usually the fastest thing to improve. There are variable amounts of posterior neck pain with this, and you've seen the patients that come out of these operations with zero neck pain and those that are miserable with what we generally label as neck spasm. But what we fairly reliably predict to patients who are expecting to have an anterior discectomy and fusion is some amount of swallowing difficulty, which I'll touch on in a moment. But as the next few weeks progress, 2 weeks after surgery, many of these patients are no longer on narcotics. Even though they have had a lot of difficulty swallowing, they feel like they're 80-90% back to normal by 2 weeks. They're beginning to drive because they're off narcotics. They feel they can move their necks better. And going further out to a month, 6 weeks after surgery, many surgeons are choosing to start physical therapy at that point to strengthen neck and shoulder muscles, improve their level of function, cervical range of motion. People who don't expect to perform a lot of exertion in the course of their job are beginning to return to work, but where there is significant exertion required, manual laborers, a lot longer might be needed to get back to work, typically after completing physical therapy, which might last 6 weeks or so. A number of things that we consider, and in the course of recovery with surgery, we keep these patients off anti-inflammatories for 3 months. In general, when any fusion is done, anti-inflammatories have a deleterious effect on bone fusion, and the critical period is probably 3 months. So these patients are generally instructed to avoid ibuprofen, naproxen, and similar drugs for 3 months. Collar use is variable among surgeons. Strictly speaking, if they have a plate put in, they don't need a collar for actual support. And the collar ends up being more comfort, a reminder to the patient and their family that they have had surgery. It keeps them from turning too rapidly. It makes them more comfortable when they're being driven around, for example. But some surgeons rely on them more heavily and insist on round-the-clock use. But strictly speaking, the idea with the plate is to avoid needing a rigid collar. The plate and screws provide pretty solid fixation, so the patients are not at risk of truly disrupting anything with day-to-day activities. I often tell my patients they'd have to jump out of a second-floor window to really disrupt anything. So they shouldn't treat themselves like they are delicate, particularly after surgery. It's reasonable for their activities to be dictated by pain. If they hurt, they should back off, but they should gradually increase their activity. While we generally admit these patients overnight, and clearly some patients need for various reasons to stay longer, there's an increasing movement to making these outright outpatient operations. Many nurses have seen the evolution with microdiscectomies, for example, lumbar microdiscectomies being multiple day admissions to being day surgery now. And the same move is occurring less in the Northeast than in other parts of the country, but more and more ACDFs are becoming outpatient procedures. The big concern with these is not necessarily pain, but the fear of a post-op hematoma and airway difficulty if the patient were at home. But the incidence of these is so low that in the healthy patient with no bleeding problems, an extended PACU stay is probably fine. So we might increasingly see 6-hour hospital stays and then discharge rather than overnight stays. Complications obviously have to be considered with these operations. The swallowing I mentioned earlier on is present in over 10% of people. I'll say early on it's much higher than this, but delayed significant dysphagia is less common, and probably you'll see anywhere from 10 to 30% range. There are a number of things that worsen it, and I'll talk more about that, but it tends to improve with time, so we're generally reassuring patients the day after surgery that they are going to get better. Hoarseness occurs at really 1% to 2% of the time in most studies, permanent hoarseness. Again, some transient hoarseness is common with these operations, but significant changes to the voice that are permanent are rare, fortunately, and occurs for a bunch of reasons, but the most concerning one is direct injury to the recurrent laryngeal nerve. Fortunately, even less common is injury to the esophagus. It occurs well under 1% of the time, but it can probably be the worst thing to deal with an ACDF. It can be a life-threatening injury because it often goes unrecognized early on until the patient develops a life-threatening mediastinal infection. Delayed injuries can present years later where there hasn't been a full thickness injury to the esophagus and the patient gradually develops a diverticulum or a pouch. But the early full thickness injuries can be very dangerous. Fortunately, again, very rare. And also very rare, but could be of catastrophic consequences to the patient, would be a cord injury. Ending up paraplegic, quadriplegic from an operation for neck pain or arm pain would clearly be a suboptimal outcome, but it's an exceedingly rare problem. Down the road, the big thing that has to be discussed with patients is the possibility that they go on to fail to fuse. I mentioned we call these operations fusions, but really the bone takes 6 to 12 months to heal. The chances of not solidly fusing and developing symptoms from that are probably in the 5% range for a single level operation, but go up with increasing number of levels. So for a 3-level operation, there's historical data that suggests as high as 40% non-fusion rate. With newer techniques, better plates, the incidence is lower, so we probably look at a 15% chance of a 3-level ACDF not solidly fusing. And these numbers are not insignificant. 10% risk is 1 in 10. The other day I was talking to I made the mistake of talking to an insurance agent about surgery, and I was telling him the risk of something was 1 in 100, and he was alarmed by that because 1 in 100 for him was a disaster. So we use these numbers fairly frequently, and they are not to be discounted. 1% is a significant incidence of anything. I said I'd talk a little bit more about the dysphagia because it's often underestimated by surgeons in particular. 20 years ago, it was discounted as a complication, a long-term complication. Patients generally did better and didn't complain about dysphagia. But it's recognized that it's a more significant thing for many patients to deal with, occurring in up to a third of people over an extended time. There are a number of things that seem to make it more common. Older patients have more trouble with dysphagia. Multi-level surgery, it probably makes sense. There's more retraction in the neck. There's more disrupted in the anterior cervical spine. So there's probably more difficulty with motility in the esophagus following surgery. For reasons that aren't entirely clear, women have more trouble than men, especially as they get older. Revision anterior cervical surgery also probably makes some sense. These are more difficult operations. And when I say highest cervical spine levels, C3-4, for example, or C2-3 carries more risk than C5-6, C6-7, and the presence of pre-existing swallowing difficulty. Now, I list these things because it sometimes factors into the choice of operation. So, for example, if I have a 70-year-old woman who has some pre-existing swallowing difficulty and has multi-level disease, that is probably not a good candidate for an anterior discectomy infusion, even though they do well in most other respects with the surgery and it will deal with their underlying symptoms, but the cost of dysphagia to them can be significant. We see some swallowing difficulty in the 1 or 2 days that they're in the hospital. Keep in mind that this tends to worsen over a few days. There's pretty good evidence on x-rays that peak swelling is several days after surgery. And the patients tolerate this at home, and it doesn't keep us from discharging them on post-op day 1 or 2, but it's important to remind them that their swallowing will feel like it gets worse because some people become very anxious about it after they leave the hospital. And it leads to returns to the hospital for evaluation out of concern that something bad is going on. Fortunately, overall, most of these patients do very well. If I had to pick 1 or 2 operations if I could only do 1 or 2 operations, then ACDF probably would be one of them. The patients uniformly do very well. Good outcomes are present in 90% of patients easily, especially for a 1-level operation. Outcomes are, most commonly worse with multi-level operations for a number of reasons, and smokers particularly because it increases the chances of a non-union significantly. So patients are generally counseled to stop smoking well before an operation. Another thing patients will ask us about is what is the risk of problems at another level in their spine if they have a fusion. The reason I don't want to have a fusion is because I'm told the rest of my spine will fall apart. The data for this suggests that about 10% of people will end up needing reoperation over time. If you just looked at imaging, a quarter of people will have significant changes at another level over the 10 years following surgery. This might be new disc herniations, it might be just worsening arthritis in the spine. But there are a couple of reasons for this. It's not just the surgery causing increased stress on the adjacent levels. 10 years after your ACDF, the reality is you're 10 years older, and your spine is 10 years older. So the underlying degenerative changes that led to your needing surgery in the first place usually will catch up at other levels and account for some of the adjacent disease. Your twin sister who didn't have an ACDF probably will have adjacent level symptoms 10 years later. So, while patients are legitimately concerned about the risk that a fusion worsens other things in their spine, the reality is other things will worsen over time anyway. Having spoken about disc herniations, the other thing that we deal with causing infrequently is stenosis. And, here, for example, I picked a cross-sectional image on MRI that shows a nerve passage that is open on one side, the right side, and narrow on the left side. I use the red lines here to try and demonstrate that difference. The nerve leaves through that, the white there is fat surrounding the nerve, and that white space is gone because of enlargement of the joint. So the compression of the nerve there will cause nerve pain just like a disc herniation will. While disc herniations tend to occur in slightly younger patients, the stenosis will occur in patients about 10 years older on average because this is arthritis, worsens with age. Our general approach with non-surgical treatment is similar. The patients do about the same with surgery. The operations are largely the same, and outcome is often from the back here. Removing this overgrown joint, or at least part of it, will unroof the nerve and relieve nerve compression and symptoms. So these, in contrast, are operations done with the patient face down, typically a mid-incision to expose the joint, drill or bite away some of the bone overlying the nerve, and then decompressing the nerve to give it more room. The postoperative course is a little different with these operations. We're not dealing with the anterior approach-related issues like dysphagia and hoarseness, obviously. They still see the same improvement in their arm pain, slower improvements in their numbness and weakness, but tend to have more neck pain initially than the anterior operations because we're going through the muscle. Because they haven't had a fusion, we can use anti-inflammatories in these patients. The concern with anti-inflammatories really would be bleeding. I think some surgeons worry more about bleeding than others after surgeries, but it's a bleeding issue that might drive the timing for starting anti-inflammatories. If the patient's operation has gone relatively smoothly, I usually don't worry much about Toradol or ibuprofen straight away after surgery. And that can help a lot with the muscle-related pain that they have. Complications are as you would expect. The pattern of complications, there's a small incidence of wound complications. Symptoms can come back because arthritis worsens or because the nerve was injured so much that decompressing it didn't solve their symptoms. They can go on to develop instability, and the nerve can be directly injured at surgery, but again, fortunately, these are common. How do we choose between these operations? Comment about disc herniations being pressure directed from the front, so lending themselves to anterior discectomies and fusion, and foraminotomies being often compression from the back, so lending themselves to posterior foraminotomies. The outcomes are very similar for both operations. So besides the pathology, disc herniation versus stenosis, there are other things that will help us decide what works better for a patient. If they have symptoms on both sides, the ACDF is usually better. Because some of the joint is being removed for a foraminotomy, it's an intrinsically potentially destabilizing operation. The patient might tolerate removing part of a joint on one side. They usually won't tolerate removing part of the joints on both sides at the same level. So the discectomy and fusion, because it stabilizes rather than destabilizes, helps. If they have neck pain, they tend to do better with an anterior discectomy and fusion. A recurring theme in spine pathology is that pain in the neck or the back often occurs because an abnormal joint is moving. And if you can stop that joint moving somehow, then you might help pain. Obviously it's not as simple as that in every case, but maintaining motion at a painful facet joint, for example, usually does not help neck pain. So if they have a significant component of neck pain along with the arm pain, that usually makes an anterior discectomy and fusion a better option. The NSAIDs, have a patient with diffuse arthritis affecting multiple joints who is totally dependent on their NSAIDs. They might be better off with a foraminotomy than an anterior discectomy and fusion because they are miserable if they come off their Celebrex or their diclofenac. So these are other things that are considered. And then other things with patient preference. Smoking, if patient simply can't stop smoking, if both operations seem reasonable in the patient, the foraminotomy might be better because the risk of a non-union might just be too high. The professional singer who cannot afford the 1% risk of hoarseness might be better off with a foraminotomy than an ACDF, even though permanent hoarseness is not common. That 1 in 100 risk might be catastrophic for them. So these are some of the things that will help go one way or the other. Fortunately, we're not as commonly operating for neck pain itself. And with neck pain here, I'm talking of isolated midline axial neck pain, without arm symptoms, without neurologic deficit. And there are a number of reasons for this. It's often, frankly, difficult for us to tell where the pain is coming from. Remember the slide I showed with the very high incidence of abnormal findings in asymptomatic adults. So the average asymptomatic patient that you stopped on the street would have an abnormal MRI. It becomes very difficult to tell that the patient who has just neck pain has their neck pain because of the findings that you're looking at on the MRI. So telling where the pain is coming from is a problem. Even if you can prove where the pain is coming from, fixing it is more difficult because unlike arm pain, which lends itself well to take the pressure off the nerve, there isn't always an equivalent thing to do for neck pain. And ultimately, for isolated neck pain, we try to operate on just one or two bad discs. If a patient has a pristine-looking spine except for one really bad disc, that patient may be a candidate for an ACDF, for example. Or if they have demonstrable things like instability or deformity, and they do not have confounding psychosocial factors that would affect their outcome, have very, very bad narcotic dependence, significant workers' comp issues or secondary gain concerns, those are factors that might argue against trying to operate on isolated neck pain. It becomes a little easier if the patient has neck pain as well as stenosis. So if there's something else we're trying to treat, then we can try and tack on the neck pain and treat that as a bonus, if you will. So if the patient has arm pain, radiculopathy, same indications as if that were the only thing they had. Refractory to conservative treatment, progressive symptoms, then we'll treat the arm pain and hopefully the neck pain will get better at the same time. And for reasons that I mentioned, the fusion probably is better for these patients, even if they have nerve compression, than the foraminotomy, because we're usually trying to stop motion in an abnormal disc or joint that's causing neck pain. The foraminotomy will deal with the nerve symptoms, but won't usually deal with the neck pain. Besides arm and neck pain, easily the next most common thing that we operate on is symptoms arising from outright spinal cord compression as opposed to nerve compression. The typical complex of symptoms with so-called myelopathy is of progressive hand numbness. The patients describe loss of dexterity. They might have gait difficulty, specifically balance, not just the inability to walk a few steps because of pain, but they are conscious of their balance being abnormal. And on exam, they often have abnormal reflexes, increased reflexes. This usually gets worse over time. The rate is variable. Many people describe a stepwise decline. So they worsen slowly. They reach a plateau that they live at for a while, and then worsen again years later, reach a new plateau, and stay there for a while. Rarely is it different from that, a more rapid decline or a sudden precipitous decline after a fall, for example. But in most people, it will get worse over time. And this usually drives the recommendation for surgery. So where arm pain usually is treated because the patient hasn't gotten better with protracted conservative treatment. With myelopathy, once we diagnose them as myelopathic, because we know most patients will worsen over time, we usually recommend surgery at that point. A patient like this who has narrowing over multiple levels, the discectomy and fusion, which works well for this, doesn't necessarily work well for that. So the typical operation is a laminectomy. Fundamentally, the lamina in the back is removed, and the patient ends up with something like this. So there's room for the spinal cord because the roof is taken off the spinal canal, basically. This works well, and again, probably adheres to the dura. So, in the normal state, you have bone covering the dura, and so the overlying muscle is not in contact with the dura. And some people theorize that once you remove the bone, scar tissue stuck to the dura can itself cause neck pain. And then, as a progression of instability, some people become outright unstable, have developed deformity, which will cause neck pain. So increasingly, there was a trend to performing a fusion. So the fusion deals with a number of the issues raised by the laminectomy alone. It prevents instability, it prevents deformity. It doesn't necessarily solve the problem of scar tissue attaching to the dura, but it at least removes some of the other things that cause neck pain. And a patient ends up with something like that, screws and rods spanning a number of levels to keep a normal alignment to the spine. The typical postoperative course is a progression of what the foraminotomy had. They usually, if they had arm pain, that's not usually why these operations are done. The arm pain often gets better. But remember, because they're myelopathic, their usual symptoms were hand numbness, loss of dexterity, gait issues. Those usually don't improve straight away. Those take longer to recover and to a variable extent. Because of the extent of posterior surgery, they usually have a fair amount of neck pain, shoulder pain. And 2 weeks later, they're usually still taking narcotics because of the extent of surgery. They're usually unable to drive, partly because of the narcotics, and they haven't yet gotten used to the limitation with their neck range of motion. A little further out, a month, 6 weeks, they're doing well enough to start physical therapy, sometimes transitioning back to work, though pain is often still enough of a reason that many people cannot after the extent of surgery, and many people are still on narcotics. Again, like the ACDF, because we're trying to get a fusion, we don't use NSAIDs. So again, fusion avoids anti-inflammatories to maximize the chances of a union. And the complications are, as you'd expect, there's risk of injuring the spinal cord and the nerves, risk of infection, but these are infrequent. Myelopathy probably improves 2/3 to 3/4 of the time. So it doesn't improve as reliably as arm pain with an ACDF. The patient who is older and has severe prolonged deficits, a patient comes in a wheelchair and is 80 years old from their bad myelopathy, is going to see far less improvement with their symptoms than the younger patient who just started to have hand numbness and weakness. It doesn't keep us from having surgery, but from offering surgery, guides us with counseling the patients before surgery. Laminoplasty is an option I use frequently, and it achieves the same goal of unroofing the spine, taking pressure off the spinal cord for the myelopathic patient, and it has some advantages and potential disadvantages. For one thing, it avoids fusing, a fusion altogether. We're not limiting the patient's neck movement to the same extent at all. The fusion with the posterior operation, just like with the ACDF, potentially puts stress on other levels of the spine, and the laminoplasty theoretically doesn't, because we're not making the spine rigid in the area of the operation. And the patients just frankly recover quicker for a number of reasons. They don't necessarily look that different for the 2-3 days they're in the hospital, but usually 2-3 weeks out, they're further along than the average laminectomy and fusion. This slide is meant to illustrate that a patient is a suitable candidate for a laminoplasty if the curvature of their spine is normal like this, but if they're kyphotic like that, we feel that they're already somewhat unstable or have deformity, so this patient is not a candidate for a laminoplasty from the start. They just already have deformity. The laminoplasty is potentially destabilizing, but not as much as a laminectomy alone, but enough that we would not put a patient who already is borderline through a laminoplasty. This patient is better with the laminectomy. And what we're trying to do is, instead of removing the back of the spine altogether, like the laminectomy, we're doing something to reshape the back of the spinal canal, put in a bone or a piece of bone or a metal plate to hold the spinal canal in a more open configuration. The images here are a little on the small side, but you get the sense that you start with a spinal canal that is this size. Cuts are made in the bone. It's levered open, like raising the pitch of a roof, and something is put in to hold that open. Again, they tend to look better 2 weeks after surgery than the laminectomy fusion. For one thing, you can use anti-inflammatories if you feel comfortable about bleeding risk. Because they're not as stiff right off the bat as a laminectomy fusion, their neck movement from early on feels more natural to them, and they just return to normal function faster. They usually still are taking narcotics 2 weeks after surgery, but they're more likely to be off narcotics 4-6 weeks after surgery than the laminectomy fusion. Also starting physical therapy and more likely to be getting back to work because of the decreased pain and improved range of motion compared to the laminectomy fusion. The complications overall are the same. One of the things that is reported in the literature specifically with laminoplasty is a C5 radiculitis. For whatever reason, and there are debates about it, the C5 nerve, which affects the deltoid and shoulder abduction seems more sensitive to injury than other nerves. So 5 to 15% of patients will have this syndrome developing not immediately after surgery, but in the 1 or 2 days after the operation, where they have increasing difficulty with shoulder abduction. And it can be quite severe in some cases and can take weeks to months to improve. Usually 2/3 of patients improve with time, but it's not just the decreased shoulder range of motion that you'll see in a patient who has neck pain because they're afraid of moving. These patients have true weakness of shoulder abduction, and it's always interesting that it's not usually present when they come out of surgery. It often takes 24, 48 hours to appear. Many studies indicate it's more common with a laminoplasty. I personally have seen it more often with a laminectomy and fusion, but it's something that patients have to be know about before surgery, because shoulder weakness can lead to quite profound deficits after surgery. It's difficult getting dressed if you can't abduct your shoulder. But otherwise, the symptoms are, the components are similar. And outcomes, again, with the laminectomy and fusion, 2/3 to 3/4 of patients improve. If they're older and they have more profound deficits, they tend to see less improvement. It's a cheaper operation. There's less hardware going into the patient. The patients recover faster. They lose less motion. They may have more neck pain because if abnormal movement caused neck pain in the first place, because this operation keeps them moving, they may continue to have neck pain. But how do we choose between the two? If they have a lot of neck pain, they're probably better off with a fusion. If they're unstable, they're better off with a fusion. If cervical range of motion is very important to maintain, occupationally, for example, for the patients, they're probably going to be happier with a laminoplasty because they can move their neck. And again, for similar reasons to I described with choosing between a foraminotomy and an ACDF, if I have a patient who's dependent on their NSAIDs for polyarthritis, they're probably going to do better with a laminoplasty because staying off ibuprofen for 3 months can be crippling for some individual. Previous patient was a 2-level operation where 1 level didn't fuse. This patient is usually better off with a posterior option, but if they had a single level operation that didn't fuse, there's good data that says they will do well with revising the operation from the front. But because revision surgery itself tends to cause more swallowing difficulty, risk of hoarseness, etc., many surgeons will favor a posterior operation. And so they end up, for example, with screws, rods, and this is the same patient just 3 months later. This gap, which was present 2 years after the ACDF, had become solidly healed just with stopping the movement at the non-union level. Instability can also cause neck pain. I showed this earlier with this vertebra slipped forward on this. If they have this happening at just 1 or 2 levels, then an ACDF works well for this. If they have multiple levels involved, then the posterior operation works better. There are increased risks with a multi-level anterior operation. Instability will also cause neck pain. Again, I also showed this. This patient had chronic severe neck pain with this baseline shape to her neck, and just restoring her to normal alignment significantly improved her neck pain, decreased her motion, but dramatically reduced neck pain. So in summary, we do surgery for a number of conditions, most commonly radiculopathy or arm pain, where I use the terms interchangeably. Arm pain, weakness, numbness in various combinations. We also do surgery for cord compression for cervical myelopathy with less good results, but we're forced to by myelopathy, but where with radiculopathy the patients are driven to surgery by persistent symptoms. It's less common that we're operating for isolated neck pain. Surgery is generally forced when the patient is getting worse neurologically. but like I mentioned a number of times, the most common reason for doing surgery is simply persistent pain refractory to conservative treatment. There are a number of anterior operations and posterior operations. There are a number of things that make us choose between one and the other. The most fundamental one is simply the direction of the neural compression. A disc herniation is operated on from the front. Stenosis at multiple levels from bone spurs is often addressed from the back. The presence of deformity usually argues for an anterior operation. It's easier for us to fix an abnormal alignment from the front. But we also take into account relative contraindications to anterior surgery. Older patients, multi-level disease, prior neck surgery. The arm pain is effectively treated with the ACDF or the foraminotomy. Myelopathy is treated by either anterior operations, the ACDF or corpectomy on the one hand, or posterior operations, the laminectomy fusion or the laminoplasty. It's less common that we're treating neck pain alone, and it often requires a fusion. Thank you.